It's my pleasure to be here and talk about hypertension and renal outcomes in clinical trials in patients with type 2 diabetes mellitus. Okay, let's analyze first of all the demographics of these two epidemics, type 2 diabetes mellitus and hypertension, in order to understand how important is the treatment of these diseases in order to stop these epidemics. Type 2 diabetes mellitus prevalence has increased dramatically over the last 3 decades, and it is predicted to reach 11% globally by 2045. Diabetes mellitus is the principal cause of end-stage renal disease worldwide, and it is responsible for up to 50% of all incident cases. You can see here that diabetic kidney disease affects most of all patients with type 2 diabetes mellitus, but also an amount of 30% of people with type 1 diabetes mellitus. In people with diabetes, when they develop diabetic kidney disease, they can increase the risk of death at least 5 times higher compared to those people with normal renal function. In those who develop early-stage renal disease, this risk is getting increased further up to 100-fold. Regarding hypertension now, you can see that in the United States, nearly half of adults live with hypertension, whereas in Europe, this prevalence is lower, but still remarkable, closing to 25%. And these numbers are expected to get associated with higher mortality and morbidity in this population, but also to provide a huge cost for the health system for medication, hospitalization, and lost working hours. All these numbers, of course, are depicted from many economic analyses. You can see that type 2 diabetes mellitus in the USA costs almost $15 billion, whereas in the UK, this amount is smaller, but still remarkable, and is projected to cost almost $1.3 billion in 2034 or 36. And we will not be here talking about cardiovascular outcomes, cardiovascular outcome trials, if there wasn't the FDA. FDA in 2008 decided to support the pharmaceutical industry in order to create new cardiovascular outcome trials for the development of new medical therapies for type 2 diabetes mellitus, having on their mind exactly all these amounts and demographics we have previously analyzed. And this guidance was further supported by EMA, and studies on renal outcomes and hypertension were generally performed as secondary measures from these CVO trials. Regarding the renal outcomes, there is a degree in the variability of the definition, and this definition includes the progression of albuminuria, changes in the eGFR, incidence of early-stage renal disease, and death from renal cause. And before moving and analyze these trials, I think we have to stop here and see how poor was the treatment before these trials. In order to reduce in the past the incidence and progression of diabetic kidney disease, we could focus only on improving risk factors such as the glycemic and blood pressure control. And the only recent drug therapy specifically for renal protection in people with diabetic kidney disease was the blockage of the renin-angiotensin and aldosterone system. And here we have a meta-analysis proving these results. And now we will move on and analyze the 3 new therapeutic categories, SGLT2, TTP4, and GLP-1, and to see that these drugs may directly improve renal function beyond any change in glycemic control, and which is the most important for these factors, as maybe in the future we can use them not only in diabetics, in diabetic population, but also in non-diabetic population. First of all, SGLT2. You can see one of the biggest trials, and I think of the first one in the field, the EMBARACE outcome, which uses 7,000 people with type 2 diabetes mellitus and established chronic cardiovascular disease. The follow-up was 3 years, and the results were clearly we're clearly showing that we have a better efficacy regarding empagliflozin when we compared this drug with placebo. And this outcome was better when we discuss about composite renal outcome measures, the progression of albuminuria, eGFR changes, and incidence of early stage renal disease. Also, Canvas trial, the Canvas progress with canagliflozin was scheduled exactly as the EMPA-REG trial with canagliflozin versus placebo. But the important here is the Credence trial, the first one, which uses type 2 diabetes mellitus patients who had already existing renal disease. And the results are exactly the same, that canagliflozin, SGLT2, could provide a better efficacy for all these outcomes. Declared TIMI58 with dapagliflozin and DAPA-HF, again with dapagliflozin, shows also the positive effect of SGLT2 in this diabetic population. And we have to stop in the DAPA-HF trial and to see that this trial was organized in order to evaluate patients with symptomatic heart failure, ejection fraction lower than 40%, and high levels of BNP. And again, the composite renal outcome measure was in favor of dapagliflozin regarding the sustained of more than 50% decrease in eGFR, early stage renal disease, and renal death. DAPA-CKD, which is one of the latest trials in the field, evaluated patients with or without diabetes and who have already an established renal abnormal function. And the GFR in this study was 25 to 75, and also high rates of albuminuria. As you can see in the diagrams, regardless of the presence or not of diabetes mellitus, the risk of the composite renal outcome, end-stage kidney disease, death from any cause, cardiovascular disease, hospitalization for heart failure, or death from any cause was significantly lower with dapagliflozin than with placebo. The second category regards DDP4, and this meta-analysis with more than 20 randomized controlled trials provided the results that the DDP4 were associated with a significantly lower risk of incident of micro and macroalbuminuria, as well as higher rates of regression of albuminuria. Here we can see that there is no difference when we prescribe DDP4 compared to placebo as regards the end-stage renal disease between the two groups. And this is the most important difference between DDP4 and SGLT2. Known trials of the field is the SAVOR TIMI53, TECOS, and the Carmelina trial with the linagliptin. Finally, GLP-1. In this meta-analysis, you can see that when GLP-1 was compared with placebo for the three major adverse cardiovascular events, the statistically significant difference was not enough to provide the clear efficacy, but there is a trend regarding GLP-1 to provide better results. The only clear result was when we compared SGLT2 with placebo. When the authors tried to analyze only the renal outcomes and divided the populations into two categories, eGFR 30 to 44 and eGFR 45 to 59, we can see again almost the same results. GLP-1 versus placebo. There was a trend in favor of GLP-1, but again, there was not any statistically significant difference, whereas SGLT2 were the only drug categories which protect the renal function in any of these two categories. LEADER trial and SUSTAIN 6 trial shows again the same, that progression of albuminuria is better when we prescribe these drugs compared to placebo, as well as the composite renal outcome measure, but the results are poor regarding the incidence of early stage renal disease and death from renal cause. There is only one ongoing cardiovascular and renal outcome trial, which is expected to be presented later this year. This trial is the EMPA kidney study, and it's one step higher than the DAPA kidney study, as uses empagliflozin in patients with diabetic or non-diabetic patients with chronic kidney disease. But here we have the difference that they evaluate patients with a lower level level of eGFR at the level of 20 to 45, excuse me. The results of the study was expected to be completed in June 2022, but 2 months later, 2 months previous, the company decided to stop this trial as we have already a clear positive efficacy for epagliflozin when we administered this in people with chronic kidney disease. We will await the results to be announced. Here, one publication from our team showing one of the most, some of the most important trials in the field regarding SGLT2 and GLP-1 and compare them for all outcomes. As we discussed for renal outcomes, I will go only to this category, and I would like to say that there is a statistically significant difference when we prescribe empagliflozin or canagliflozin or any other category of SGLT2, liraglutide or semaglutide in patients in order to improve their renal outcomes. Here is the difference with the hypertension. As you can see, in hypertension, we have a little bit different results. Epagliflozin and canagliflozin are very capable to lower systolic and diastolic blood pressure, and this affects systolic blood pressure at around 4 millimeters per mercury for each of these drugs compared to placebo, whereas the epagliflozin, liraglutide, and semaglutide could affect blood pressure, but not in such a big effect, providing such a big effect, excuse me. And here again, one publication from our team showing the forest plot with a summary effect of meta-analysis of RCT trials regarding SGLT2 and its effect on systolic blood pressure. As you can see here, in all of this meta-analysis, the weighted mean difference is approximately 4 millimeters per mercury for systolic blood pressure when we administrate SGLT2. And here, the latest meta-analysis, 43 RCTs with more than 20,000 patients, which show that epagliflozin could affect better the systolic blood pressure, whereas canagliflozin could affect better the diastolic blood pressure. And finally, GLP-1 and its efficacy on hypertension among patients with type 2 diabetes mellitus. You can see that GLP-1 can decrease the systolic blood pressure with a range from 2 to 4 millimeters per mercury when compared to placebo, but the reduction in diastolic blood pressure is modest and it is significantly only for exenatide when we prescribe this drug twice daily for 10 milligrams. To conclude, SGLT2 inhibitors have significant and clinically important benefits for renal outcomes as they can reduce the rate of progression to macroalbuminuria and delay the decline in GFR associated with with diabetes. DTP4 may improve the rate of progression of albuminuria in patients with type 2 diabetes mellitus, but they can't influence the progression of eGFR, the incidence of early-stage renal disease, and the rate of renal death. Finally, regarding GLP-1 analogs, again, we have a clear composite renal outcome effect and a reduction of the progression of albuminuria, but they also can't affect and impact on changes in eGFR and the incidence of early-stage renal disease. Regarding hypertension, SGLT2 can better control hypertension. GLP-1 have also a positive impact on blood pressure, but especially when we talk about systolic blood pressure and not about diastolic blood pressure. Thank you very much for your